Dr. Basak is the director of the Disha Eye Hospitals in Kolkata. He has had special interest in cornea and has also written a textbook on corneal diseases and has several publications on the subject. So I welcome Dr. Basak to this program and I invite you to give your lecture. Thank you.
Thank you. Thank you, sir. Thank you, Professor Saxena, for this wonderful series. I am a part of this, and now I will share my screen. So, is it okay?
Yeah.
Am I visible and audible?
Sure, sir. Please go ahead.
So my talk is on endothelial keratoplasty. We call it EK. I do not have any financial interest to disclose. My sincere thanks to Professor Abhijit Kaur, head of the department, and Professor Sandeep Saxena, and all the faculties of Ophthalmology Department, KGMU, Lucknow. I also acknowledge some good YouTube videos, my cornea colleagues, our iBank staffs, my patients, and other colleagues for referral. And also my daughter, who believes we live in the newness of small differences, and it inspires me. So stories will forget their beginning, and in forgetting, we'll eat other stories. But then 25 years from now, things may be different. So exactly 25 years back, the only options for PBK or Fuchs dystrophy was PK. And we all know the disadvantages of PK, means penetrating keratoplasty, that delayed rehabilitation, longest visual recovery time, poorest visual quality because of high astigmatism and also irregular astigmatism. Like this patient with beautiful graph is having astigmatism of 9 diopter. There are also further problems like surface and suture problems, more graft rejection, graft infection, greatest risk for trauma and wound dehiscence, frequent and long-term follow-up, and long-term use of steroids. Then the evolution of endothelial keratoplasty came in 1996 with PLK, called posterior lamellar keratoplasty, then DLEK, deep lamellar endothelial keratoplasty, then in 2003, Dissection, Desmet stripping endothelial keratoplasty, and 2006, that is by automated, A stands for automated, DSAEK. Then in 2007, DMacc, Desmet membrane endothelial keratoplasty. And if you see that the graph, this is US data. So actually in 2011 and 12, where the EK surpluses the PK, the blue one is the PK is gradually decreasing, whereas EK, endothelial keratoplasty, is gradually increasing. So if you see the EK data separately, you see that in last 9 or 10 years, this is US domestic surgery report, and you see that the EK number, endothelial keratoplasty number, is increasing every year. And if you see that both the components of EK, like Dissection or DMacc, you see that Dissection is actually decreasing, and you see that DMacc is increasing in number. In India, about 100 or more surgeons are doing EK regularly for last 10 to 15 years. And probably we are doing about 5,000 to 6,000 EK per year. What I am talking about pre-pandemic era. So what is the basic difference? The upper graph is just Dissection, We remove, in both the cases, we remove the disease descendant membrane and endothelial complex, which is about 14-15 micron thickness. And in Dissection, we just replace it with a posterior lamella from the donor cornea, which includes DM, endothelium, and posterior part of the stroma. Whereas in DMacc, we remove 14 micron and we replace it with the 14 micron. So both the things are endothelial keratoplasty, but the difference are here we are adding more amount of stroma, where in DMacc we are not adding any stromal element. That is why in Dissection it is the same patient, both eyes. In one eye I did Dissection long time back, and you see that there is increase in corneal thickness, and you can see the posterior lamella and the junction in anterior segment is OCT. And whereas in DMacc, it is just like a normal cornea, except that you will see a small inferior PI in the lower part, 6 o'clock position. So what are the indications of EK? In one word, it is just endothelial dysfunction. So either Dissection or DMacc, whatever you do, it is the endothelial dysfunction. So in the Western world, the indications are a little different. This is one of the largest series published about 4 or 5 years back, where they have shown that their commonest indication is Fuchs endothelial corneal dystrophy. We call it FECD, is about 80% of the eyes. And pseudophakic corneal edema or bullous keratopathy post-cataract surgery, that is 8.5. The range is like 60 to 65% in FECD and 15 to 20% in PBK. And other indications like failed PK, failed previous Dissection, failed previous DMacc, and this congenital hereditary endothelial dystrophy, posterior polymorphous corneal dystrophy, and miscellaneous causes are also there. But when we come to our country, the Dissection and DMacc indication in India in PBK or post-cataract corneal edema is about 75 to 80%. Whereas FECD we see less, it is 15 to 20%, and there are other miscellaneous group. So we published our data last year only, and you see that in our series that we see little more number of Fuchs dystrophy in this part of the country, and the incidence we see is around 36%. So first I will talk about Dissection. I know there are a lot of general ophthalmologists and PG students and residents are there. So the Dissection donor preparation usually done by automated or by manual method, but I am still practicing manual method. This is the artificial anterior chamber where we have mounted the sclerocorneal ring. Then we use the splitter. We used to use this splitter during SICS wound, and same kind of, we are going in the lamellar way. So it is like 2/3 thickness roughly. So we have different intraoperative pachymetry measurement. We can decide about the thickness. And then we go across the cornea from limbus to limbus, all around 360 degree. So now when we touch the other limbus, opposite side and the sideway limbus, that is our dissection is completed. This is a closed dissection. So after that, we take the button in a Teflon block. Then we just light penetrating keratoplasty. We take the desired diameter of button, like 7.5 or 8 millimeter button. The same thing can be done by automated method, like in LASIK flap in the left hand side. So here 350 micron blade is using, and we are just removing the anterior flap. This is actually is an open method. What is remaining is the posterior part. Similarly, there are Different kind of machine. There are 4-5 kind of machines are there for automated lamellar preparation. Basically, it will act just like your microkeratome to make the LASIK flap. The basic steps of Dissection, and if you see that, so you see we get this type of cornea, and this is typical PBK, and there are a lot of loose epithelium. You have to remove it first for template mark. This is template mark 8 to 8.5 millimeter, because we want to score the desmet from behind, from anterior chamber, like I will be coming late. Then the incision is just like a SICS incision, either superior or you can give it temporal. Internal incision actually will be like little, this template mark is there. So internal incision should be outside this template mark. And you just give entry with 2.5 millimeter keratome and then gradually extend it on either side. And you have to make 2 side ports. Sometimes these are stitchless, but sometimes you need to put 1 or 2 sutures at the sclerocorneal junction. The side ports, actually, you can make it like in our regular phaco side ports, 15-degree blade. So in DMacc, the incision is smaller. It is either anterior limbal, mid limbal, or post limbal. I prefer a post limbal little, because then I do not have to put any suture, and also the astigmatism is a concern. Normally we give 3 to 3.5 millimeter incision, whereas in DSAK or Dissection, the main incision is around 4.5 to 6 millimeter, depending upon your graft size and indication. Then this desmet scoring and desmetorexis. This is either done under dilated people. If you are combining a surgery, this is very important. You do the just FECD cases with cataract. So if you do under dilated, so you get a good visualization. Whereas in pseudophakic cases, sometimes we stain the DM with trypan blue so that you could see better. People also used air-assisted desmetorexis, where also the visibility is very good. But Hilon is the only, Hilon means cohesive ovidis. Cohesive ovidis is very important, because you have to remove all the viscoelastic material from the anterior chamber before putting a graft. So now you have to donor insertion. So there are many techniques. People are using glide technique, Busin glide. I use this forceps taco technique, and also needle push technique of 30 gauge needle. You just go fold it and then deepen the anterior chamber, and from one side you create an angle, one side you actually inject here. So when you inject here, after that, after air tamponade, you center it. You center it from external, or you can go in the interface to center it. So you see a double golden ring. This double ring is very important, that you are in a correct position and correct orientation. This S stamp is very important, S or F stamp, that we more often use in DMacc, but not all cases of Dissection. So in Dissection, after 10 to 12 minutes, we remove part of the ear we actually exchange with BSS, balance salt solution, and hydrate the side port. You may put 1 suture if you are not sure. And this 8 millimeter air bubble should be there. And patient is instructed to lie down in supine position for at least 4 to 6 hours before sending home. This positioning is very important, because that air will constantly giving pressure over the donor lenticle, so you have a very good donor adherence. So manual Dissection is going since 2006. It is going good in my hand. I am a volume cornea surgeon. Across the country, people know that I used to do around 250 to 350 keratoplasty. And mostly 80% of them are actually endothelial keratoplasty. So the results are consistent with this manual Dissection. And till now in our hospital, almost 2,500 surgeries has been done. And the results are actually constantly giving better. So if you compare manual Dissection with DSAEK, I have compared my series with other series, and it is going at par. And there is no difference. In fact, the endothelial cell loss in my series is also similar to Western world report. And I have published those data. This is one of my patients, actually, I wanted to share with you. This is the two eyes of the patient, right eye and the left eye. Accidental injection of betadine inside the anterior chamber during surgery 15 years back by some operative surgeon, and developed TAS, and that's why the iris has been changed. That is heterochromic iris. And this was done in August 2006. This patient just followed up with me. Every year he used to come. Last July, and you see that the endothelial cell density is so good, almost 1300. And I know that this eye will be going for another 10 years. Now I'll be talking something about DMacc. As I told you, DMacc is Descemet membrane endothelial keratoplasty, 14 or 15 micron versus 14, 15 micron. So my first DMacc, actually, I have done in 2009. It was just accidental. Just I was trying, and I got Best of Show Video Award in that conference in 2009 in American Academy. But without much understanding, I must confess, and then failure in 5 eyes out of 8 eyes. Then several attempts every year and more failure. I stopped doing DMacc and I only concentrate on Dissection. That is the problem with the DMacc, that initial failure rate, if you do not understand the physics behind the surgery, probably your failure will be much more. So every year I do practice in wet lab and I do few cases and more failure. Then in 2016, a lot of changes across the world has happened in this time because people are sharing their video in YouTubes. You have a lot of people you are going, they are now opened up. So you ask some question, you will get answer from the masters. So I have now understands that yes, DM scroll and the types, they are different. Anterior chamber fluid dynamics, unfolding or unrolling of DM scroll, is marking stamp on the DM side of the graph. Surgery is going on and smooth in most of the cases and also in challenging cases. Actually, this S stamps on DM side made our life easy. People used actually P asymmetrical mark, P, F, S. So everyone has a S is on stromal side, S is the savior, your surgery will be smooth, and you always be, there will be no chance of you are putting the graft in a reverse orientation. So it is actually indicator for successful surgery. So my initial few cases where now I understand that what was my problem. So initially I selected the good indicated cases like FECD with cataract, primary cases, or recent PBK or corneal edema with good visibility, with good anterior chamber anatomy, round normal pupil, IOL in the back, no vitreous disturbance, everything is important. My initial, I did not tell that I am going to do DMacc. So Dissection or DMacc I used to write in my prescription. So there was no active marketing for DMacc at that time, 5 years back. So my initial donor tissue is also very selective. So these are also important for beginner surgeons, that your donor age must be between 55 to 65. You take little higher count cells because your initial donor manipulation will be more. So there will be more cell loss. So you take more number of cells and keep some standby optical quality tissue and try to keep extra time with you, because the initial surgery time, Dissection like it is within 15 minutes, but initial surgery time for DMacc was 45 to 75 minutes. But now it is 14 to 20 minutes in plain DMacc cases, and in triple DMaccs I have recorded it is, I have published this also, it is between 17 to 32 minutes. So you finish the whole lot of surgery when you know the tricks and usual cases. So then I started work with homemade injector, because there are many injectors, those are glass injectors, but every day you will get a new, if you have the IOL cartridge AR40, you know that this is actually sensor multipiece by Johnson & Johnson. You just break that cartridge and fit with a rubber part of the IV set. And it is always available, it is of no cost. And you have to fit with a 2cc syringe, and you just see there is any air leak or not. It is absolutely tight. You take the donor graft in the cartridge. This is the injector system. Every day I make new. There are other glass, they are expensive. And there are also confusion about that the glass is slightly better because it causes less endothelial cell damage, something like that. But if you practice one particular method, you will be always better and better in that method. So one of the important difference in DMacc is inferior PI. So either you can do it externally or you can do a vitrector, and you have to, because of little blood oozing will be there, you have to give air tamponade actually. That prevents the blood ooze, because we know that if you give air tamponade for 3-4 minutes, the bleeding time of that particular person, so it will stop. Sometimes we can do EAC PI beforehand, and if the periphery is good and visibility of the good. So we can do 1 week before inferior EAC PI. We have done few cases only. So at this point, when I put AR, at this point, I actually prepare the donor tissue. So these are simple instruments. People have many methods. I use the simplest method of using this as a McPherson forceps, simple tapnol block. This stromal punch is done because you have to make a stem from the DM side. This window is open on the stroma. You soak the fluid and put a stem. This stem is on DM side, not on endothelial side. So 8 millimeter is the usual graft. So you just take 8 millimeter and then separate the graft and do Trypan-Bluch staining, because Indian eyes, it is very difficult because of brown or deep colored iris. So the background will be also more difficult for operation. So then I try to see the scroll type. There are different types of scroll: classical double scroll, reverse double scroll, tight scroll, seagull-like. Then there is no scroll actually. No, it is just like flat. It also depends on the age of the recipient. If you take a younger age group of patient like below 50, you will have always tight seagull-like scroll like this upper corner, upper right corner. And you see that this all scroll behavior is different. Then you take the thing in the injector system. This is a case of PBK, and you put the graft in. Now you have to do very carefully. Someone actually put one suture in the main port. I normally do not give any suture. So you have to look carefully which side is which. Try to recognize that S mark. Most of the time it is difficult, but the scroll behavior, that endothelial is downside, your scroll pattern is also important. When you are sure, you just put little air and you can see that S mark, which is actually very good visibility after putting a little bit of giving Hilon. So your S mark is visible. That means you have done a nice job. Normal, initially the unfolding time is actually sometimes 10 to 15 minutes, but now it is between few seconds to 1 to 2 minutes. Most of the cases, difficult cases, of course, few minutes are required. So immediate post-op, keep the patient in the recovery room for DMacc patient, and again maintain supine position for 1 to 2 hours. Normally in DMacc patient, you need not keep the patient for 10 minutes in the operating table, and maintain supine position in the recovery room for 1 to 2 hours. Then examine under slit lamp if you have the system, or examine in the ward. And in sitting position, you have to check the air bubble position. If it is above the PI, we want to see that air bubble should be above the inferior PI. That means everything is fine. If not, we just burp little air from one of the side ports, either by 26 or 30 gauge needle, or maybe a part of McPherson sterile. And then again, we find a little bit of fluid level. So fluid level should be above the PI. So there will not be any pupillary, air-induced pupillary glaucoma. Usually in pre-pandemic era, we used to keep our patients overnight in the hospital, but nowadays we are releasing the patient after 4 to 6 hours, and we always see the patient on day 3. So there are little differences between Dissection and DMacc. So case selection in Dissection and DSAK are not so crucial, but DMacc it is very crucial. Good anterior chamber anatomy, round and normal pupil. Donor preparation, manual or automated. Most people used automated, but here the donor preparation is only manual. Main incision, as I said earlier, 4.5 to 6. Here 2.8 to 3 millimeter. In recipient preparation, DM scoring same size, whereas in DMacc it is larger than the donor. Inferior PI not mandatory in Dissection, but it is mandatory in DMacc. Anterior chamber should be deep during insertion of Dissection graft, but in DMacc graft we purposefully keep it little shallower because we are injecting little fluid along with the graft. Graft transport easy. There are many techniques. It is difficult and only by injector system. Donor unfolding, unscrolling easy with BSS and air, but it is the most difficult part and mostly no touch technique. You have to mark the DM side, asymmetrical mark. Donor centration in Dissection is easy. DMacc it is difficult because always it try to float in one side. Air injection easy, but here it is difficult. So you have to give air from the center. Otherwise there will be decentration of the graft. And flat supine position at both the cases are early mobility probably in DMacc. People ask me Dissection or DMacc, which one is the preferred method in EK? Today's era, the answer is DMacc. So if you see the Dissection, actually it is not anatomically perfect. And also we now know that it is not visually perfect. We are giving 6/9 vision in most of the cases. And you know that this thickness is increasing from 80 to 120 micron on an average. Whereas DMacc, you see that this is the pre-op OCT of the picture, and the next day, day one, you see the corneal thickness has reduced to half. And it is actually perfectly anatomically, you cannot make out the graph actually, this higher chance of 20/20 vision. So in my series, about 40% to 60% of the patient actually achieves 20/20 vision with no correction or minor 0.5 cylinder correction. So a dil mange more. And we know that advantages are many, but disadvantages, we also know that there is least rejection in DMacc, 0.9 to 4%, whereas in Dissection, the incidence of rejection rate is about 7%. So only disadvantage is very difficult and steep learning curve. Tissue damage is high in initial stages, higher chances of donor detachment, but when you learn the technique, there will be less and less. We have published our different series, and endothelial cell loss in our series is like 33% after 1 year. Then this is my batchmate, MBBS batchmate. You see that the PostOp 4.5, 4.5 years, how the endothelial cell count is on right eye. Left eye still yet to operate, but it is a Fuchs dystrophy. And this is also another doctor, my neighbor. He is also doing fine. So DMacc that way is doing fine. We have worked with DMacc PD. PD means peripherally trifinated graft. That is only possible with DMacc, not possible with Dissection or PK graft, because here we are putting only 14 micron, 15 micron. So normally the superior cornea is having higher endothelial cell count than this central endothelial. And we have published our paper in Cornea Journal, and you see that we have not making it central, we are making it eccentric graft. So it has been published last year only, and we have shown that that endothelial cell count in the donor DMacc PD is definitely higher than that of DMacc CD, means centrally the conventional graft. And this is one of the typical example. I have operated this patient, 2 eyes in a gap of 4 months, and you see that I have given that DMacc PD in the right eye, and her cell count is like 2,400, and DMacc CD in the left eye, and their cell count is just 1,000. So after experience, this is another question often asked. So many cases of DMacc, do you still prefer to do Dissection in case is any of the cases? The answer is yes. Typical indication for Dissection in current era who are also doing DMacc, the aphakia with large pupil, aphakic bullous keratopathy with large pupil, aniridia with glaucoma drainage devices, post-VR surgery with bad pupil, acephalus, some of the cases of shade or ophthalmos, one-eyed patient with poor anterior chamber anatomy, and you have extremely poor visibility. Just in last 5 years, you see that when I started doing DMacc, it is gradually increasing, whereas in Dissection, it is gradually decreasing. In pandemic era, it is little more because we have less number of tissue, so we do not want to lose one tissue doing a difficult DMacc. That is also to be concerned. So Dissection is now for more difficult, like PBK with overhanging blade, post-trap IOL. And you see that at the same time I did blade repair with scleral patch graft and Dissection, post-operative 2 years, doing excellent. This is extreme Fuchs dystrophy with cataract, no visibility. I did Dissection triple with SICS, and this patient is also doing fine. So 60 months DMacc surgery learning and 15 years Dissection learning Every day there is a new learning. So it is sometimes difficult and sometimes it is not easy. And sometimes you will see that 70 or 80% time the tissue will listen to you. Rest of the time your experience will tell you that how you should go. So, and centration is difficult in DMacc, and never try to be 100% perfect for centering. Probably you will lose that tissue. So always counsel the patient about the probable donor detachment, and also the incidence is around 4 to 18%, and counsel about the need of rebubbling, just putting a AR bubble or C3F8 gas or SF6 gases. So all are important learning. Dissection or DMacc, both are difficult when the IOL is in the sulcus, very high myopia, post-VR surgery, post-trap, tube, ACIOL, aphakia. There are a lot of controversial people are always, they are doing differently in different case scenario. So take-home message is in India, cataract surgery rate is now in a new high, approximately 5,000 per million per year. You know that 6.5 million cataract surgery done in 2019-20. So that means every year we are adding PBK or corneal edema. If we calculate 0.2%, so every year we are adding actually 13,000 new EK patient in India. We have also significant numbers of Fuchs endothelial dystrophy in our country. Manual Dissection is good, reproducible, and least costly, and affordable to the common people in India. So now DMacc, again, we are back to manual dissection. DMacc cannot be done in automated procedure. So your hand will speak. So now you need to rethink about huge investment on an expensive microkerato. We need to reinvent the wheel. For India or any other developing country, the choice of EK will be either manual Dissection or DMacc. We need more number of trained corneal surgeons with good incentives for them. At the same time, we need more number of good corneas. That is only possible if we develop eye bank within our own community. Needy patients are there. It is a matter of practice and attitude. Thank you very much for your patience hearing.